pain. This represents the distribution of diagnoses that we met during the study. And this table is that we find only 3 things in the 6 things we studied, which were the parity of the patient was a non-leprous or multiparous, and the presence of cervical pathology in the form of adhesions or a lesion or infection or some sort of stenosis, and the duration of the procedure if it took them more than 2 minutes. In nulliparity, we experienced that about 26% of patients, nulliparous patients, experiencing pain, severe intolerable pain, in comparison to only 11% in multiparous or non-nullipara patient. That means that the relative risk that the patient which is nulliparous is 2.3 times more prone to experience pain than multiparous patient. Again, in cervical pathology, it was about 40% of patients experiencing pain in comparison to only 15% of patients with absent pathology. That means that the patient almost 3 times more prone to experience pain while she has cervical pathology. In cases of failure cases, we had actually very few number of failed cases, which were 6 patients. So statistics couldn't find out what correlates mainly with pain, but in all patients, our 6 patients, they had cervical pathology also. That's what I was talking about, that if we have more than one variable controlling pain, like nulliparity or cervical pathology, or the duration of procedure. For example, let's say that older nulliparous patients were menopausal. So is it because they are nulliparous or menopausal? So we did a multivariate analysis in order to know the factors which are really statistically significant for pain. And again, we found nulliparity, cervical pathology, and if the duration is more than 2 minutes, were associated more with pain. Our discussion to this, that most office hysteroscopy is a really successful painless procedure, that in most of our patients, only 2% of cases fail to do hysteroscopy. Plotting our result to the literature, we found that there are about 9 other trials concerned with our same concern, the factors affecting pain. 3 were randomized controlled trials, and 5 prospective trials, and 1 retrospective trial. Our number of cases was a good number between them, and most of them agreed to that. We didn't do that in our study, but that could be the reflection of what we were saying, that most of the studies said here that the size of the instrument is significant in most of these studies. So this is a reflection of what we were saying, that the cervical pathology or the problem of the cervix is the main problem that might face us during doing office hysteroscopy. So we conclude that nulliparity, presence of cervical pathology, and duration of the procedure more than 2 minutes are associated with pain, and on the other hand, the menstrual phase, being secretory or proliferative, the menopausal status, and the presence of uterine pathology are not predictors of occurrence of severe pain during office hysteroscopy. So we think that the nulliparous patients or patients with cervical pathology are those in need of either preparation of the cervix before doing the procedure or taking analgesia during the procedure, and we need further larger studies to discuss the factors that might affect failure of doing the procedure. Thank you very much.
Thank you, Dr. Khalid, for this presentation. We can have some questions from the floor. So if anybody, please, Professor Ahmed, please.
Many thanks to Professor Muhammad. واحنا كلنا بنعرف خبرة أستاذنا الفاضل الدكتور محمد في مجال الهيستروسكوبي، ولكن في كومنت حضرتك اللارج مايوما، يعني هل الهوم مسج ان يعني نقدر الهيستروسكوبيست with average experience can do this, and what is the factors which to overcome these problems؟ يعني احنا اللارج مايوما انا اشتغلت على كنا بنستخدم الزولادكس مانثلي، ولكن كانت في مشكله كبيره ان احنا كانت بعد decreasing السايز كان يحصل ميلتنج between the capsule of the myoma and the myometrium، فكانت في مشكله في البلين اوف كليفج. فحضرتك يعني عاوزين خبرتك في المجال ده.
Thank you for this very important observation and comments. Actually, as I mentioned at the beginning, and it was unfortunate that I made my presentation for large myomas. However, for most of the hysteroscopists, as Professor Ahmed have mentioned, that we do not recommend that an average skilled, of course, hysteroscopist to perform such cases, especially with deep myometric extension. And as we know that if you have more than 50% of the myoma within the wall of the uterus, then probably you are very close to the surface of the uterus. I have performed sometimes laparoscopy and hysteroscopy simultaneously in some of these cases. And if you have really a deeper myomas, and we have done some of the cases even with most of the myoma within the wall. So literally speaking, I have performed 1 or 2 cases with subserous myomas, actually in the sense, with hysteroscopic resection. But this was really frightful because the way that we did the slicing within the wall of the uterus was really very scary. Using the GNHRH, as regard the GNHRH, as I mentioned, I never use it, and for the simple reason that it will make the differentiation between the myoma and the bed not really very obvious, and this will increase your difficulty in recognition of the when to stop resection. However, it is very important sometimes to use it when you have severe anemia. In general, for these cases with severe anemia, I have confronted cases with hemoglobin of 4 and a 5, with patients with large myomas. Most of them, if you have severe bleeding, most likely the case will be type 1 or 0 within the wall. The more the uterine cavity, the more the myoma is within the cavity, the more you will have bleeding, the more chance that the patient will have anemia, and the easier is the resection. So fortunately, most of the symptomatizing patient with pain and bleeding are more into class 1 and a class 0. So this is an advantage actually in recognizing when a patient comes to you in the clinic and she has this kind of pain and bleeding severe enough to produce severe anemia. You are very lucky because usually those patients have type 0 or type 1 myomas. So for type 2 myomas, usually I do the multiple slicing technique because you need to give some time with sessions. Don't extend your slicing time for more than 10 minutes. Wait, deflate the uterus, let the uterus contract, let the uterine wall to reform, let the myoma to be pushed into the cavity so that you have more of the deeper portion now into protruding into the cavity, so slicing is considered. However, the last portion of the myoma, when the smaller part is remaining, you still have to do it inside the wall. I mean, this means that with deeper myomas, you cannot get them all inside the cavity by just uterine contractions. So you have to manage the last portion of the myoma within the wall. And so this is very important that you need. Of course, if you have a fundal myomas, this is very difficult. If you have a lower corporeal, that's difficult. If you have a corneal, extremely difficult because of the thinner wall of the uterus. So you need to assess exactly the situation, the size of the myoma. Also, another important feature is the size of the uterus itself and the number of the intramural myomas. If you are doing cases with a fibroid uterus of 16 and 18 weeks because of the numerous intramural myoma, expect it to be very difficult because you cannot have a panoramic view. You have to be very close to the uterine wall. You have to be very well oriented within the cavity. I'm sorry, only those who are performing hysteroscopic myomectomy can really know what I'm talking about. For those who do not perform any hysteroscopic myomectomy, I think they will not understand what we are talking about. Yes, please. مفيش ميكروفون تاني. mentioned so that we know that this is right. You're talking about the patients who have a 12-week size pregnancy with a fibroid uterus, multiple fibroid uterus, right? 10 myomas, and all of them are intramural or some of them are submucous. Still, she has some submucous myomas, right? Or you don't know yet? And intramural myomas and 12 weeks, and she has recently a recurrent, a missed abortion, right? And only one time. I mean, she has only one abortion. Two miscarriages. Okay, so we are dealing here with a case of a fibroid uterus, multiple fibroid uterus, with a submucous myoma. And what kind of investigation did she perform? Only ultrasound? Basically what she mentioned that, first of all, as I mentioned in my previous talk, that we need to do a office hysteroscopy always is a very important issue to measure and to identify the number and the size and the site of the fibroids. We know that submucous fibroids are quite related to recurrent miscarriage. The intramural fibroids, as I understand, if there are 10 fibroids and then the size is only 12 weeks, we're talking about only very few centimeters. Okay, so to the largest one is 4 centimeters, the smallest one. Okay, I think we need to know exactly what is the size of the fibroids, but in general, let me answer this in a general way, that when we have an office hysteroscopy and then we identify the submucous myomas, then those are the ones who need to be removed. The intramural fibroids are not, as all the studies have mentioned, that it's not clear the relation between intramural fibroids and the recurrence of recurrent miscarriage. But definitely the hysteroscopic myomectomy would be an idea for those patients, but only at least 3 months after the miscarriage to identify the normal size of the fibroid. So office hysteroscopy will be done only 3 months after the miscarriage to identify and investigate the size and the site of the fibroid. So of course, other possible factors of miscarriage should be identified before you perform the surgery. Any other questions?
سؤال how can avoid fluid overload during prolonged operation? Actually, you have to be ready to stop the procedure at certain point. If you have utilized an excessive fluid, you have a large fluid deficit, you have to stop the procedure and you can continue in another session. That I would like to actually, we have two problems. We have the type of fluid, they have the length of the operation, and the possibility of vascular trauma, which leads to an excessive intravascular escape of the fluid. If you have a lengthy operation, you have a large deficit of fluid, you have to stop the operation and to complete in another session. No problem. I would like actually to give a small comment about this myomas penetrating in the myometrium. If you are not able to finish at the same sitting, there is no problem. Continue in another setting. And you may not resort to the slicing technique. You can use a Versa point. You can use a tweezer electrode or something like that, which will vaporize the myoma at its place. So you have another tricks, not necessarily the same trick. You can resort to another setting, you can resort to other forms of bipolar electrodes, not necessarily the slicing technique, but adapt the instruments and the facilities at your hand to the procedure you want to perform. That's why actually I wanted to say, you have the possibility of morcellator, you have the possibility of bipolar loop, you have the possibility of VersaPoint electrodes, you have several possibilities to use the safest at hand. Huh? Okay. I would actually comment on this. There is a Japanese studies which correlated the size of the intramural myoma with the pregnancy outcome. I know there are several alterations that are not correlating with it, but they defined that a large intramural myoma has something to do with the pregnancy outcome. Not only the pregnancy outcome, with the delivery outcome, you have a big possibility of postpartum hemorrhage of such myomas. Huh? Yes, that's I'm trying. So it is no problem that to perform to remove multiple myomas by open procedure, and those with intracavitary, you can remove it by hysteroscopy. What is the problem? No. Why? You are not obligated to perform a hysterectomy. Actually, I can't find the problem. I didn't put my hand on the problem now.
We are running out of time because there is a session. I'm sorry about that. So we can talk about it later. And one last question because we need to close. Yeah. في other questions? Any other question, please? Okay.
الإيشور كويل هو ذكر الهيستوريس.
الإيشور.
محل كيوبا فاصوليا. هي موجودة أصلا في مصر؟
No. Okay, any other question? One last question for you. You want to comment?
No. لا أنا كنت بتكلم عن اللي هي الكيس دي. There is no problem.
Thank you very much for your attention, and we'll see you next year, hopefully. Thank you.